Today, we're on site for day 2 of ISPOR's annual conference in New Orleans. We will be recapping some of the top news presented each day during the meeting, and soon we'll speak with Dr. Julia Slejko, an assistant professor of pharmaceutical health services research at the University of Maryland School of Pharmacy, about incorporating the patient voice into value-based decision-making, and Dr. Michael Sherman, the Chief Medical Officer of Harvard Pilgrim Healthcare, about ISPOR's value-based price assessments. Welcome to AJMC On Location. I'm Jamie Rosenberg. During the second day of the meeting, sessions surrounded value and different mechanisms of determining cost effectiveness. First, there was a session on ISPOR and its value-based price assessments that inform payer access decisions. Another session took a look at different approaches that leverage real-world data in order to extend the survival curve in cost-effectiveness analyses. Finally, a session explored additional elements of value that could be included in value assessments of new drugs. Read coverage and watch additional interviews from the meeting at ajmc.com. First up, we have Dr. Julia Slejko. Thanks so much for being here.
Happy to be here. Thanks for inviting me.
So, in the shift toward value-based care, why is it so important to have multi-stakeholder collaboration that includes the patient for value-based decision-making?
Well, I think what's really new about including the patient in our center is that not only are we thinking about the voice of the patient in our economic evaluations, but we're really trying to use, as you say, a multi-stakeholder approach. So thinking about patients, providers, patient advocates, which is really different than patients themselves, and finally payers. Because whatever analyses that we do, we want it to sort of reflect the patient journey, but also be in a format that payers can use to make decisions, or other decision makers can use.
And why is it important to get input from a variety of patients who have different experiences or diseases and thus have different values when it comes to their health care?
Yeah, I think that's just so interesting. In the past, I have performed economic evaluations from more of a traditional approach, and I haven't really reached out to patients to understand their journey through their condition. And I think that what I've learned in the work that we're doing right now is in chronic disease, and some of the things that I hadn't really considered at all in my economic models in the past have really been brought to light for me. For example, in pulmonary disease, we're really focused on exacerbations or lung function in terms of major outcomes in our cost effectiveness analyses. But when we've talked to patients, we understand that really what they're telling us is more important to them is like medication frequency, side effects, more of the day-to-day burden, which may be impacted by exacerbations or lung function, but it's specific particular things that we could do a better job in our economic models. So just kind of understanding their priorities helps me prioritize that in my model inputs as well. So, that's in chronic disease, but I would imagine that in other disease states, it's very, very different. Especially one thing that we hear is about ability to plan. So patients with chronic disease might not know how they're going to feel in a week or a month or whatever. That might be very similar in other diseases for very different reasons, though. So I think, understanding the value elements that are important to patients across different conditions can make a huge difference how you interpret that in your model.
Are there any novel approaches being taken to incorporate the patient voice?
Yeah, so I think there are a lot of people working on this issue right now, which is great because it's a tough issue. So, there are a lot of really cutting edge methods that are being used in terms of eliciting preferences from patients. There are also new ways of evaluating our information like MCDA, which is multi-criteria decision analyses, and other types of like stated preference methods. And so there are a lot of people who are doing different things to kind of get at this question. And we've been eliciting things from patients for a long time. It's just that translation from the information that's coming to patients to actually informing our cost effectiveness analysis, that's where things are really kind of new, and we really have to be bold with the methods to really expand that science a bit.
And are there any challenges with translating patient values into economic evaluations?
Yeah, there are a lot of challenges. I think the challenge is for one, quantifying what those value elements are, and then second, really how do you interpret the information? So quantifying something like the ability to plan your life, that's a little bit hard to quantify some of those things, but that's why we're spending time on this topic. some of the things that we find that are important to patients, we already have methods for. It's just that we didn't realize how important they were. And so it's kind of, okay, a prioritization of what are the things that we're spending our time on in our analyses. The other thing that has been really interesting is just the approach that many different groups who are addressing this issue are coming at it from different directions. And so I think that really makes kind of this really well-rounded approach to this new science, and opposing views as well, because not everybody's going to agree with some of the new approaches, but yeah, it's definitely an exciting time.
And are there also challenges with trying to balance patient values with the values of other stakeholders for decision making? For example, what's something a clinician might find of value?
Yeah, so talking with one of my clinician collaborators on this, he really had pointed out a lot of things that were, again, in pulmonary disease, I talked to him about some of the things that we typically use in our cost effectiveness models, and it's also things that prescribers are really thinking about when they're making decisions for their patients. But then on the other hand, they do want to know what's important to patients and what kinds of things that they might be able to optimize as well by making a little bit different treatment decision. I also hypothesize that patients who are getting treatment that's more aligned with their preferences would tend to be more adherent to that treatment, and then that would result in better outcomes down the road. That's really an area that I want to focus in on in the near future as well.
And so you're part of the patient-driven values in healthcare evaluation at the University of Maryland. How does the center approach the inclusion of patients' values and the challenges that might be faced when doing this kind of work?
We really take like a bottom-up approach. So really some of our research has started with patient advocates to get an idea of generally what things are important. And so that's the approach that we're taking in our study of COPD right now. So they gave us a sense of, across many diseases, what attributes are patients interested in their treatment, what outcome-related things are important, but not specific to pulmonary disease. Then with that, we created a set of domains, and we can kind of map those onto things that are, we know from the literature, more traditionally things that COPD patients care about. But then we go back to COPD patients themselves and ask them about it. One thing that's been really interesting in the patients that we've spoken with is we're recruiting them at the point of care. So we're not recruiting them from a group of patients who are, typically engaged in advocacy, and that would be worthwhile maybe later on. But right now we're really talking to patients who don't have necessarily a good sense of value assessment or cost effectiveness or health economics or anything like that. We're just really asking them about their experience. And I think that's been very, very revealing, just to understand from kind of your day-to-day patient, what is it that's on their mind and what they care about. And then for me to think about, well, what can I do better in my cost effectiveness model so that it really reflects what these patients care about. Like, for example, finding out that side effects is really important to patients made me think, well, I'm not sure that that's something I've spent a lot of time on in my COPD modeling in the past, even though we have methods to deal with that. And, it's standard practice in modeling to incorporate side effects. I'm not sure that I really had the right evidence to inform those model parameters to the degree that they represented how important it was for the patient experience.
Right. And does education play a part in the center's work? Have you found that education for both patients and healthcare professionals is important for ensuring that value assessments successfully include these patient voices?
Yeah, and that's a core of our center that's taken on by some of our partners at the National Health Council, and they're responsible for a lot of the education core activities, so they can probably speak to that a little bit better. But they have a number of trainings in place that are about kind of basics of health economics, or even more advanced trainings about value assessment, and I think that they find that people feel really eager to learn more about it. Especially they work with patient communities and patient advocates, I believe. So it's very interesting.
Very well. Thank you so much.
My pleasure. Thanks for having me.
Here with me now is Dr. Michael Sherman. Thanks so much for being here.
It's great to be here. A lot of very exciting and very timely topics to discuss.
Yeah, definitely. One of them being ISPOR, which you talked about earlier today. So speaking of, how has ICER's value-based price assessment helped fill a void in the U.S. for payer decision making?
Well, as you know, there's no a framework in place in the U.S. that we've universally adopted, so ICER stepped in to fill that white space. And if you think about it, you really want people in a position to make decisions about coverage to be thinking about the value, not responding knee-jerk to just a high price, because trying to maximize for lowest price may be the wrong decision if what you really care about is quality and the total cost of care. So ICER really does provide some needed tools, even though it's admittedly controversial.
Right, and can ICER also be used to determine if there's evidence for price increases with all this increased scrutiny on drug price increases?
Well, there's a lot of scrutiny on drug prices, and particularly, as you mentioned, everyone is looking at drugs that are not new to market that have had price increases. And it's sometimes tough for people to figure out, is it warranted or not? So ICER is actually embarking on a new project starting this year where they'll look at the drugs that have had the largest price increases, evaluate the evidence, and determine where they warrant it or not. And at least it'll serve the discussion and help us get a better feel for which cases really are justifiable.
Great. And as more novel and expensive therapies continue to enter the market, how has the role of ICER become more important in determining the value of these drugs?
Yeah, so we're seeing the onset of a time when we're going to see more and more expensive drugs with price tags we've never ever imagined, 7 figures and all. But the fact is, in many cases, they serve unmet needs, so we shouldn't be reacting blindly to just a price tag, but we need to really think about that in the context of value. So given the pressure on health plans to manage expenses, because our expenses are someone else's premium and cost, so given that, the more tools, the better to understand in what cases the prices are warranted, and in some cases they will be. In other cases it may help spark a discussion and perhaps a negotiation. But the higher the price tag, the more we need to be having these debates.
Great. And when determining the value of a treatment that comes with a high price tag, is it also important to keep in mind the unique characteristics of the disease it's treating? For example, if it's a chronic disease with serious quality of life issues, or if it's a disease that doesn't have any approved drugs?
Absolutely, and to cite one recent example, ICER has traditionally looked at qualities or quality adjusted life years, yet it is a fair point to make that could, and so I don't know if I would use this word, but some would use the word discriminate against those who are partially disabled or may not be able to return to full function. So with their assessment of Zolgensma, which we believe is the next gene therapy to be approved, they actually looked at the fair price using the traditional quality methodology and then came up with an imputed price based on just life years gained, where they actually essentially assumed everyone had a 1.0. So I think that they need to be doing more of that as we look at different types of diseases and appreciate the sensitivity. And again, even for someone who has a partial response, that's still very important to them, and particularly for rare diseases, may very well be worthwhile. So we don't want to inadvertently discriminate against those who have these conditions.
Great. And are new methods going to be needed to determine the value of curative therapies, which come with a one-time but high-cost payment and also have limited evidence regarding their long-term value?
Well, perhaps. So I believe that we can fit those into the existing frameworks, although ICER and others are looking to modify them. But the bigger issue here is if we're going to see therapies come to market with, again, very limited evidence, but truly serving an unmet need where we want to make them available, we're going to need to not just figure out what they're worth, but how to pay for them over a reasonable period of time, and only pay for them commensurate with demonstrating that continued response. So we have a whole lot of pieces to put together. But again, ICER needs to inform that. And again, based on their original framework, where at the upper end they've looked at a certain dollars per life years, it really was not created anticipating a curative therapy. So we don't look at a child who's gone to the hospital for a life-saving surgical procedure and say they'll live another 70 years at $150,000 a year. Let's write a check to $10 million for the hospital. Again, drugs are expensive, gene therapies are expensive, so there's an answer in there somewhere, and it may justifiably be a large number, but we need to think about that differently.
Right. And with assessments following methodologies adopted by health technology assessment agencies like NICE in the UK, are there challenges with reflecting the values of the US within the assessment, adjusting it to the values of the US?
Well, there are many challenges, although we do look at NICE in other countries in the absence of a quote-unquote nationally adopted framework here, and we look at ICER and others as well. But the fact is, NICE has teeth behind it. As society, they made a decision that if drugs are priced at a level that is too high, they won't cover them. And we're not in a position to make that type of determination. I'm not sure the American people are ready to do that. The other thing is, in many cases, countries that have frameworks and price points that have teeth may be later in the game in terms of having certain drugs availability. And again, we need to think about our value society and how we balance the pieces. So it's all good information, and we look at it when there are assessments, but it doesn't necessarily apply to our market in our country.
Right. And what, if any, are potential solutions to address these different challenges with adjusting it to our country?
I think we need to experiment. I think we all need to acknowledge that even though we sort of pretend that there's no cap on what we can spend in healthcare, there is a practical limit, and I think everyone needs to be responsible, both on the payer side, the pharmaceutical side, provider side, et cetera, and think about demonstrating the value and coming up with innovative payments that allow for the price to be paid when they're effective, but also remove the risk of not paying for an ineffective treatment, which, since that would be a deterrent to coverage. I also think we should think about different carrots or sticks to incentivize companies that are willing to price responsibly and show their work and demonstrate how they got to that starting price, whether through ISPOR or another framework. So I think there's a lot of opportunity here to collaborate, but the point is we need to be working together, not pointing the fingers at one another in public.
Great, thank you so much.
You're very welcome.
That's all for today. Stay tuned for tomorrow's AJMC On Location, where we will sit down with Dr. Youssef Zafar, Associate Professor of Medicine and Population Health Sciences at Duke University School of Medicine and a medical oncologist at Duke Cancer Institute, about incorporating patient-reported process measures in value-based programs, and Dr. Lou Garrison, a professor emeritus in the Department of Pharmacy at the University of Washington, about the benefits and challenges of using the quality-adjusted life year to determine cost effectiveness. Thank you for watching AJMC News Network. I'm Jamie Rosenberg.